Um segundo aqui.
Hi, everyone. Welcome again to our PPCR Journal Club sessions, and we're really honored to have today Karen Vasquez, medical doctor and also research fellow at Professor Fredney's lab. Karen was a PPCR alumni for 2020, and she was one of the best students also in our group, and we're really happy to have her today. So Karen, thank you so much for your time and for preparing this great discussion with the students, and you also may find the paper at Google Classroom for you that want to follow her discussion. Thank you.
Thank you so much, Karen. We look very much forward. Thank you.
Thank you for having me, and welcome everyone to the PPCR 2021 Journal Club. So for this discussion, I'm going to start talking a little bit about what's the TDCS, something that my colleague in the previous journal club already did, but I wanted to just do a quick reminder of that. And this is mostly what we're going to talk about today. Okay, so the TDCS is the abbreviation that we use for the transcranial direct current stimulation. This is a non-invasive, safe stimulation, a brain stimulation technique, and it's an intervention that targets the neural pathways of the brain through low current electricity. And depending on the electrode that we are using, it can either stimulate or inhibit these pathways. And this will eventually change the neural system, leading to its modulation, hence the term neuromodulations. So data has shown that this intervention is useful for several medical conditions such as stroke, aphasia, major depressive disorders, schizophrenia, chronic pain, among others. We've seen in some of the guidelines that we have that these results usually occur after frequent sessions, and that each session usually lasts between 20 to 30 minutes. So with this information, I would like to ask anyone, you can open the mic. I'm not following the chat, but if you want to talk, feel free to do it. If you were going to plan to do a study with this intervention, what would be the challenges in the study design that you will think about it? Anyone?
I think that in the blinding.
Go ahead.
I think that in the blinding, you should do a double dummy strategy. But I think that it will be challenged in the blinding.
Anything for the other types, other steps of the study design, something else?
I also would say the placebo.
Exactly. Perfect. Something else? Okay, so regarding what someone said about blinding, this was also an issue because usually you want to test like an active and a sham, right? So what researchers also thought about this, and they developed like a sham protocol in which they will mimic the initial feeling of the simulation during the ramp up period, like when it's starting. So they will apply a little bit of current in the initial, like for 15 seconds or 30 seconds, depending on the protocol, at the start and at the end of the simulation. So patients may believe that they could be having this simulation even though they were sham. So this has proven to be successful. However, we have to take into account that also electricity causes vasodilation. So sometimes beneath the electrodes that we're putting, we're going to have a skin redness. And that's something that the patient or the subject can realize and say, like, start thinking, oh, maybe I'm inactive, or maybe I'm in the sham. For that, we don't have something like to conceal it. That's why it's important to think about having assessing the quality of our blinding using questionnaires. Also, it's important to take into account the placebo effect. Just by maybe you're sham, but just because you're feeling that, you can have that. And also, as I said previously, these stimulations usually require time, and it required for patients to come several times to your research lab. So this will affect recruitment, because it's a time commitment. Because, for example, if we're doing a simulation that's going to last 20 minutes and the montage, if it takes a lot of time, would be 10 minutes, that's already 30 minutes. And we are asking them to mobilize to our lab and then go back home. So that's a time commitment. Sorry? And also it can affect adherence. So for this challenge, also researchers thought, like, it would be great if this stimulation could be done at home, right? So that's why we are the article that we're going to talk about. It's something novel because it's using something that's been used in a lab by certified people doing it, and now letting the patient do it. But we have always to think about the safety of the patient and also the feasibility of it. So that's why today I bring this article by Anne. It's called Efficacy of Combining Home-Based Transcranial Direct Current Stimulation with Mindfulness-Based Meditation for Pain in Older Adults with Knee Osteoarthritis. So basically they created this trial because they saw that TDCS was useful in chronic pain, for improving chronic pain. And also in the literature, we found that also mindfulness-based meditation it has also showed small to moderate effects for improving pain. So they thought that, okay, so how about we combine these two simulations, adding the fact that we are doing a home-based transcranial direct current stimulation, and see if they kind of have a synergistic effect, meaning that it's going to like potentiate the effect of each one of the stimulations and like generate a greater effect to see if they can improve pain. So this is the last paragraph of the introduction. Usually in these paragraphs they put like the objective of the study, and usually is where we find the research questions. So based on this, can someone tell me the PCAT with what we have here, please? For population, what would be the population?
Hello. So the population here, I think, would be older adults with knee osteoarthritis with limited mobility.
Mm-hmm. What would be the intervention?
It would be the 2-week home-based TDCS paired with MBM.
What would be the control?
Control here.
They don't say it here, right? That's something that's missing. What would be the outcome?
So the outcome here would be the osteoarthritis related clinical symptoms.
What else?
and experimental pain sensitivity in older adults with
Mhm.
knee. And they don't say the time of follow-up, but
Exactly. They just say that it would be a 2 weeks experiment.
yeah,
They
that's right.
have follow-up. And they will also have clinical pain. Perfect. Thank you, Daniel. So as Daniel said, the patients that we will have will be patients from 50 to 85 years old with knee osteoarthritis. The intervention would be active home-based TDCS plus active mindfulness-based meditation. And the control in this case would be the sham home TDCS, and they also added a sham mindfulness-based meditation. The sham mindfulness-based meditation, they explain it as it would be just like sitting and being conscious of your breath. Whereas in mindfulness-based meditation, you usually are guided to be mindful of your body, of the position of it, and then of your breath, and then they will add more stuff. So that's what they call sham MBM, okay? So for the outcome, as Daniel said, we will have clinical pain, also the osteoarthritis-related clinical symptoms, also some experimental pain sensitivity that I will explain later, and also really important is the feasibility of these home-based TDCS, and the time will be 2 weeks. So regarding the outcomes, we are going to have the numerical rating score of pain, that's abbreviated on NRS, in which 0 is no pain and 100 is the worst pain inimaginable. We will have the Western Ontario and McMaster University Arthritis Index, or the abbreviated the WOMAC. This is a scale that measure pain, measure osteoarthritis, symptoms like stiffness and all that stuff. And higher scores mean that's a higher severity degree. So they also talk about the pain pressure threshold in the lateral and medial knee. So the pain pressure threshold is a test that's going to evaluate the deep muscle sensitivity. I want to show you this video so you have some like see it in your mind. They are going to start applying some pressure, and they say to the patient, like, when this pressure becomes painful, you let us know. Yeah, for the example, in that moment, in that pressure thing, in the algometer, sorry, the patients are like, oh, it hurts, so they stop and they get that number. Okay, so I want to, so they have this, and they're going to see the change of that, and also they're going to see the condition pain modulation. This is more like for the experimental pain experience. So the condition pain modulation is a surrogate outcome of the endogenous pain modulation system, and is based on the paradigm that pain inhibits pain. Meaning that, for example, if right now I hit my hand with the table, I'm going to experience a pain of, I don't know, 5, let's say, yeah? And then I walk and I hit the leg of the table in my knee, and there's going to be another pain stimuli. But this pain stimuli kind of going to decrease my initial experience of pain in this arm. So if this was 5, now is 2 after I hit my contralateral leg. So in this case, what they do here is they are going to they're going to put the stimuli, as we saw in the YouTube video, and the patient will say like, okay, my pain pressure threshold is this number, yeah? And this pressure will be the test stimulus. And after I did that, I record that, and then I'm going to, in the contralateral side of the PPT stimulation that I did for the knee, I'm going to immerse the hand of the subject in cold water. That's also a pain stimuli, and I'm going to wait for 30 seconds. They ask also how much is the pain for that part, and then after those 30 seconds, still with the hand inside the water, the frozen water, I'm going to put the pain pressure. I'm going to put the algometer so I can test the pain pressure threshold. So with that, the objective is that if you have a condition pain modulation, so meaning that you have an functional endogenous pain modulation system, your pain pressure threshold should increase, right? So that would be like if you have a functional one in this case, and if it didn't, we will consider that it's dysfunctional. You have to take into account that the interpretation of this is based, for example, of like if, sorry, the interpretation of this, it will be based on the context of your design on what you're looking for, because the CPM can be interpreted differently and also uses different techniques, but for this article, this is how they did it. And for the feasibility, they're going to do a patient satisfaction questionnaire in which they will just ask some questions regarding easiness of putting the things, how confident they are feeling, and all that. And they will rate 0, like 0 I agree, or no, 10 I agree, and 0 don't agree. And that's that. So this was a single center, double blind, because neither the participants nor the experimenters were aware of the intervention. It was randomized, it was sham control. They did 10 daily sessions of 20 minutes over 2 weeks. So the patients did it from Monday to Friday, rest the weekend, and then Monday to Friday. So those were the 2 weeks. So the participants who met the eligibility criteria were randomly assigned to the intervention group or the sham group. And in total, they had 30, the sample size was of 30. And they used for randomization the method of minimization. Does anyone remember what's that method that could explain here to us? That you remember that there was like stratified, block randomization, adaptive randomization. Do you remember the method of minimization in which one of these was about?
I remember it is an adaptive method of, right? Of
Yes.
randomization.
Yes, correct.
I remember something like using covariates of the participants, and then something like the assessing the balance of the covariates between participants. I don't remember it.
No, but you did great. That's what I wanted. Like they in the method of minimization, as you said, is an adaptive method of randomization, in which they use an algorithm to they randomized based on covariates. In these cases, that for them it was important for them to assess for the age, race, and sex, and they used like an algorithm for that. But you did great, perfect, thank you. Okay, so this is the table 1. So I want to, so you can say it like, do you think that the randomization was successful or not based on all this?
I think regarding some characteristics, they are unbalanced, right? Like the education, you can see that there are more subjects in the sham group regarding like 4-year college or like also the doctoral degree. You have 4 with doctoral degree in the sham group and 2 in the active group. So there are some. It's not really quite bad. It's not a good balance, I think.
But as you see, like for the ones that we adjusted, like for example, age, sex, race, they are.
Yeah.
So
Yeah.
that's positive. And something also it's interesting, and it would potentially, it's something that we will have to take into account when we are analyzing our data, is that if we go to the NRS, we're going to see that there's a higher level of pain in the active group compared to the sham group, right? So that's also something that we can think about it. Okay, so moving on. Okay, so for the statistical analysis, this description is for the demographic table that we just saw. So could someone explain me why are we using 2-sample t-test, or also known as Ampere t-test and chi-square test, based on the variables that we have?
I think that it is a feasible test because they are assessing continuous variables, like the score. And I think that is a simple test, the most simple to use to find statistical significance.
Perfect. Okay, and also it's important that they assess for normality. So that's why we are also using parametric tests, because they assess for normality using the Shapiro-Wilk test, and it was normal. So the next step is, okay, so now we can use parametric tests. And as you said, we have continuous variables and we're comparing 2 groups. So that's why it would be Ampere t-test and not per t-test. And for the chi-square test, we are using categorical variables. If you were part of the team doing this, would you have changed anything regarding this analysis? Taking into account that, for example, our sample size is small, like of 30?
I don't know.
No, don't worry.
Fisher.
Exactly. We could think that that it would be better to do a Fisher exact test. And before moving on, I also want to ask you, like, all these statistical analysis for this part is for the demographic table, right? So here we see like the p-values, but I want to ask you, like, how useful do you think it is to have a p-value in a demographic table? Like, do you think it's useful? Should we continue doing it? Does it gives a lot of information for you?
I think it doesn't give that much information because I think it would be like an exploratory analysis because the study wasn't designed to assess for these comparisons. But I guess it's just done because it's a convention and all papers do it. But really, I don't see how this can contribute to this comparison can contribute to the interpretation of the study.
Exactly. Thank you, Daniel. So you said something really important is that these p-values aren't powered to see this difference because we like this the sample size that we have for this trial was based on pain clinical outcomes. So we power our study based on that, not based on age or sex or race. So one thing this will show us that, okay, it can be underpowered. And also with these kind of tables, it's easier to just go like you did previously. You just saw it, like you didn't, if I didn't give you the p-value, you just told me like, okay, here it's a difference, there's a difference, like the point estimates you were able to give me and interpret them based on that, and not, you didn't need the p-value. So that's something that you have to also take into account, like everything that you put in the paper should be something that will give the reader information and would be useful. It's not saying that, I'm not saying it's wrong to do it. However, if we want to create like a more mindful research reporting of stuff, it's something that we have to take into account. And for the data that they recollected, we have to take into account also two things. One, when did they recollect the data, and what data they recollected. So for example, we are going to have all the clinical pain outcomes and also experimental pain outcomes that are continuous variables. And most of them are going to be recollected at baseline and also at the end of the 2 weeks, except one, that is the NRS score, that it was measured at baseline and also after every stimulation session. Okay, so that's why they decided to use an advanced model of linear regression called the linear mixed effect model, in which this model helps us to, it's kind of like, it's a type of linear regression that measure that you can like assess both the multiple time points, for example, in the NRS score, and also adjust for covariates such as the ones that they say here, race, sex, and also the baseline score, like since the start. So that's why they did that. And also they not only wanted to see if there was a difference between the groups, but they want to quantify that difference, like what's the magnitude of that difference. And that's why they calculated the effect sizes, the Cohen's d effect sizes. And the rule of thumb is like when you get like 0.2 is a small effect size. When you get 0.5 5 or 6, it's a moderate, and 0.8 is a large effect size. However, you have to take into account that this is like a convention that was proposed by Cohens to kind of standardize like the way of like standardize the results. So like if someone independently of how you measure the things can say, oh, this effect size is this and this, and can understand it. However, you have to interpret these results based on the context. Because if, for example, if I'm measuring height, like 20% from the standard deviation, it's not going to give me like such a difference, right? Like, so if I get like in the case of 0.2 as the effect size, and in that case, yeah, it's a small effect size, like it doesn't give me a lot. But for example, this exact effect size that it's small can be huge for a patient that's tetraplegic and was able to move a little bit his thumb. You know, like you have to think in the like in the context that you're assessing, and also taking into account all the literature to assess and interpret these effect sizes. So they assess for this is the flow diagram. As I say, they assess for eligibility. 38 patients, eight were not interested in the research, so they ended up with 30, which were divided in 15 and 15 to both groups. And they analyzed also 15 because they didn't have withdrawn. If they would have I don't know here 2 withdrawn and still analyze the 15, how would you call that analysis? Does anyone know?
Intention to treat analysis?
Exactly. In which you analyze all the subjects that were randomized independently if they didn't continue. Perfect. Okay, so for the results, we can see that they didn't gave us like the means, like the baseline, like the previous ones, and the post, like baseline and post treatment, but they gave us the change, right? So for pain, for example, these scales of for these scales of pain, for NRS and WOMAC, we want to see a decrease, right? So we can see, for example, that in these there was a decrease. However, we can see that in the active group, there was a higher decrease, and also the effect size was larger. Yeah, for example, in the NRS, it was really large. And also in the WOMAC, for the pressure pain threshold, you want that the threshold to increase, right? So that's why we will be looking for positive values that we can see here in the active group that they had, while in the sham group they didn't. For the CPM, as I told you, we're also looking for the same, and here it's also positive. And we can also see here the effect sizes that are also large. So we can say that there was a significant difference between sham group and active group, and that the magnitude of the effect was, in most of them, it was large. And regarding the feasibility, that's also really important, is we can see that they had 10 questions, 10 questions, and they usually, as I said, 10 was strongly agree, 0 was strongly disagree. And for the one that it was easy to prepare the device, we have like values near 10, while the device was unnecessary complex. Well, here it shows that it's lower the scale. So that's something that we would like to see it to assess, like, okay, so it was easy, they didn't find it like any difficult to do it and all that. So based on what I showed you and also what you read, what limitation did this clinical research study had, like that you could identify? Like,
I think that the first one was the sample size.
Why?
Because I think that was 30 subjects. So for example, you couldn't apply the central limit theory if the Shapiro test wouldn't assess normality.
And you can also, it will affect generalizability, right? Or, okay, what else?
It's a very small size study, so
Sorry, can you repeat, please?
Oh, I mean the sample sizes or only 15 subjects in each arm, so.
Exactly.
However, I don't think that this affects too much the study because it is a pilot study. So, for example, isn't a phase 3 study that you have to generalize to the entire population.
Exactly.
But in fact, it is a limitation. It's more difficult to find statistical significance.
Perfect. Thank you very much. Okay. So, as you said, one of the limitation is sample size. Another limitation would be, I think that it was Daniel or someone else. Sorry if I don't remember your name. That they didn't have a follow-up period, so long-term effects can't be analyzed through this using this study. Also, we had active intervention in which we had an active TDCS plus an active FMBM compared to a sham TDCS and a sham MBM. But we didn't have like one arm only with mindfulness-based intervention and one arm only with TDCS. Why is this important? Because maybe there is no synergistic effect and just using TDCS alone is enough without mindfulness, or just mindfulness alone without the TDCS gives the same effects. But we can't assess that because we didn't have those arms. So that's important because we can't say like, oh yeah, with this we know that TDCS plus mindfulness-based therapy is the way to go. No, because we haven't compared with what we have previously, and that's really important. And also something that you have to take into account is how is the meditation that they said a sham is actually a sham, because by just breathing and being conscious of your breathing, you are already changing some stuff. So that's also something that you have to ask yourself. Regarding the reporting, in the eligibility criteria, the patient, like one eligibility criteria was that the patient was not going to change like the pharmacological therapy that they were having. And because we're talking about pain, we need to know what analgesics are they taking, because there's a difference between taking opioids and only taking NSAIDs. But we need to know that, and it's something that it was missing from the report. And also, as I told you previously, we got the change of the change of each one of the clinical outcomes, but they never gave us the result, like the mean and SD of the post intervention. And you may ask yourself, like, well, why it's important? Well, first, it's a way of verifying, like if you were like really through, you can verify like, oh, the change is accurate. But also because you have to also think like in a broader spread, like broader image, in which you're going to have to, this is a pilot study, so it's small, and there may be other studies that also assess this. And in the future, someone can say like, oh, let's gather all these and let's do a meta-analysis or some to see if it is actually useful or not. And we need all these, when you're doing a meta-analysis, you need all this data, the pre and the post, because many articles, they report this and not the change. But the change, you can just mathematically do it by yourself if you have these two values. But without this, you are going to have to go like to think other ways to get to that result. So it's also something that you have to think like, if I'm doing this article, it's also like to give someone else another step so we can all, like, it's kind of like a brick over a brick, so we can all generate like common knowledge. So that was also important and something that was missing there. So in the end, the conclusions that we can, like the take-home messages that we can take from this article is that the combination of the active home TDCS and mindfulness-based meditation showed statistically significant results for improving pain outcomes compared to the sham home-based TDCS and the sham MBM. Regarding feasibility in both groups, there was overall easiness regarding the preparation of the device and the use of it. And also, I think that I didn't mention it, but while they were doing the simulation, it wasn't like they were doing it all by themselves. They were connected like maybe via like remote supervision, maybe via Zoom, something like that. So the research team could guide them like in case something happened. And they thought that the participants thought that was helpful, and in the end they felt confidence regarding the use of the device, which it's really good, because that's something that you want, like that the patients feels like know what they're doing, so not any like mishap can happen. And regarding safety, that's something really important. They didn't report any side effects, so that's also that also means that there was a good tolerability regarding that. Okay, any questions? Okay. I don't know if someone wants to say something and something else. Thank you for your time and for joining. And that
Thank you
was
very much, Karen. Yeah, it's a great talk, and yeah, very good example.
Thank you, Steven.
So Thank you so much, Karen. I was also tracking here in YouTube if you have any other questions since we're streaming live. So great discussion, and thank you for showing this pilot study. We know that there were many limitations on how all this was related, and it's really important that we, every time that you analyze a paper, you review all this, in the sample size, meta randomization, and of course, this, when we're designing a pilot study, it's also really crucial because we're trying to see if something can work or not, and the design is really important too. So great, everyone. So see you this Thursday, and thank you for joining today. Have a nice night.
Bye. Thank you, guys.